is defined as myocardial cell death resulting from prolonged ischemia, which is a lack of blood flow and oxygen to the heart muscle. Clinically, we identify it by a characteristic rise and/or fall of cardiac biomarkers, alongside evidence of acute myocardial ischemia. The prodromal phase involves symptoms occurring days or even weeks before an acute event. These are not just vague complaints, they are clinically significant predictors of future cardiac events. Remarkable: 85% of ACS patients report at least one of these symptoms before their acute event. In studies examining these early warnings, unusual fatigue and anxiety were reported 100% of the time. Shortness of breath or dyspnea was noted in 86% of the studies. Other common prodromal signs include arm pain or discomfort at 86%, and gastrointestinal complaints like nausea or indigestion at 71%. Chest discomfort is only reported by 57% during this phase, while jaw pain appears in 43%. Case study: the U.S. Woman Prospective Study. A study of 1,097 women identified that discomfort in the jaw, teeth, and arms, alongside fatigue and dyspnea, were the strongest predictors of an event. Women reporting just one of these symptoms had a fourfold increase in cardiac event risk within the following 2 years. The recognition gap. A major clinical hurdle is that only 41% of patients attribute these symptoms to their heart. Consequently, only 40% seek medical attention for this warning shot, leading to missed opportunities for early intervention. Women are statistically more likely to experience prodromal symptoms than men, at 85% versus 72%, with a p-value of less than 0.001. This difference is highly significant and necessitates a sex-specific approach to history taking. Women often present with 3 or more symptom clusters. A typical female presentation may include severe referred pain in the shoulder or back, sleep disturbance, anxiety, and a sensation of the heart racing. Acute presentation: chest pain versus other. While chest pain remains common, women often report it with greater severity and in referred locations like the jaw or back. Furthermore, dyspnea is the primary symptom for 48% of women compared to 40% of men. The impact of age in symptoms and presentation. Sex difference in presentation are most pronounced in patients aged 45 and younger. Young women are significantly more likely than young men to present without chest pain, though this gap narrows and nearly disappears by age 75 to 84. Women generally present with acute myocardial infarction 2 to 10 years later in life than men. This is often attributed to the cardioprotective effect of estrogen before the onset of menopause. The older adult population, greater or equal to 75. The Silver AMI study found that 44% of older adults did not report chest pain as their primary symptoms. Crucially, these include 40% of patients who were actually experiencing a ST elevation MI. In geriatric patients, clinicians must look for weakness, dyspnea, or silent ischemia, where ischemia changes appear on the ECG without the patient reporting clinical symptoms. A typical presentation is deadly. The 30-day mortality rate for a typical presentation is 7.7% compared to 3.6% for typical symptoms. This disparity grows at the 1-year mark to 15.6 versus 7.5. Patients without classic chest pain have an odds ratio of 2.07 for mortality. This means they are twice as likely to die as those presented with classic crushing chest pain. Major adverse cardiac events, a composite of death, MI, and stroke, occurs in 18% of atypical patients within 30 days, compared to 13.5% of those with typical symptoms. Why are atypical outcomes worse? Worse outcomes stem from the delayed presentation, patients waiting longer for help, as well as diagnostic delay in the ER and lower rates of guideline-directed therapy. Disparity in treatment. Women with ACS are less likely to undergo PCI and less likely to be discharged on essential medications like statin or ACE inhibitors. Addressing this disparity is a clinical priority. The 10-minute rule. For any suspected ACA case, the 10-minute rule applies. An EKG, troponin test, and a history of physical must be performed within 10 minutes of arrival. ECG findings in non-ST elevation ACS. In NST ACS, 31.3% of patients show ST segment depressions and 11.7% show T-wave inversions. However, 41.2% have a non-diagnostic or normal EKG, emphasizing the need for biomarker testing. High sensitivity cardiac troponin is the gold standard for modern cardiology because it detests much lower levels of cardiac protein, allowing for much faster rule-in or rule-out MI. The European Society of Cardiology recommends blood drawn at arrival and at 1 hour. It uses specific threshold to measure the delta or change in troponin levels over that hour. This algorithm has a negative predictive value of approximately 99%. It can safely rule out MI in up to 70% of patients immediately, which is significantly reduced ER crowding. The 0-3 hour alternative. Many US institutions use a 0 to 3 hour protocol. If two measurements taken 3 hours apart are normal, the negative predictive value for ACS remains approximately 99%. Interpreting the troponin pattern. An acute MI requires a dynamic, rising or falling pattern. Conversely, a stable, persistent elevated troponin level often indicates chronic injury from conditions like kidney disease or heart failure rather than an acute event. Introduction to risk stratification. Risk stratification is used for patients with normal ECGs to see if they can safely go home. The objective is to identify patients with less than 1% risk of an event within 30 days. The modified HEART score. The HEART score assesses history, ECG, age, risk factors, and troponin. This tool provides structured way to quantify clinical suspicion. HEART score outcomes. A score of 3 or less is considered low risk. These patients are eligible for early discharge as their 30-day death or MI is only 0.4%. The emergency department assessment of chest pain combines clinical features with troponin results to increase safe discharge rate without missing events. The TIMI score consists of 7 equally weighted variables and is a validated tool for predicting short-term mortality, particularly in non-ST MI patients. Non-invasive options, coronary CT angiography, is a specialized scan to visualize the coronary arteries. It is an excellent for ruling out coronary disease. If the CCTA is normal, no further testing is typically required. Stress testing and echocardiography. Stress testing evaluates the heart response to physical or pharmacological stress. Bedside echocardiography looks for wall motion abnormalities, which are segments of the heart that are not pumping correctly. Cardiac MRI is essential for identifying MINOCA, infarction without obstructed arteries, and helps differentiate MI from myocarditis or Takotsubo syndrome. Key clinical implications. High suspicion. Always maintain high suspicion in women, the elderly, and diabetics, even when they deny chest pain. Standardize care by utilizing validating high sensitivity troponin protocol 0 to 1 hour or 0 to 3 hours. We must begin viewing prodromal fatigue and anxiety as an early window to intervene before a full infarction occurs. This table highlights the stark difference between typical and atypical presentation, particularly the double mortality rate and the frequency of delayed recognition in atypical cases. These citations reflect the state-of-the-art research from the Journal of Cardiovascular Nursing Circulation, JAMA, and Lancet. Thank you so much for your attention.